In my last video, from sewers to stethoscopes, we saw how 19th century engineers built the foundation of public health by improving sanitation and providing clean water supply to people. Despite not being medical professionals understanding biology, these 19th century engineers succeeded in improving life expectancy. And they did this by improving the infrastructure, where and in which people lived, which are now called the structural determinants of health. In the decades following the great bifurcation between clinical medicine and public health, the arc of history in the mid-20th century converged to create the perfect storm that changed healthcare forever. This historic split cemented clinical medicine, which included treatment of individuals and their diseases, generally in hospitals, over public health, which was more focused in keeping people healthy in their community. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut, and I run my own medical practice. These mid-century historical developments not only changed how healthcare would be delivered and financed in America, but it also shifted our mindset from viewing health as a collective responsibility to viewing it as an individual responsibility. This video is the story of path dependency, capitalism, and the rise of hospital insurance duopoly in healthcare. Let's dive in. By the end of World War II, American hospitals were in crisis. Many facilities were built in the early 1900s and were obsolete. The rapid urbanization and population growth left vast gaps in coverage, especially in rural areas. At that time, the United States had only approximately 3.2 acceptable community hospital beds per 1,000 people, which was again approximately one-third below what was needed. For patients, this often meant crowded, open wards with poor sanitation, a far cry from the vision of a modern scientific hospital. Since the Great Depression had frozen municipal bond markets and wartime priorities soaked up steel, cement, and labor, there were no resources to build the hospitals to care for people. This created a perfect storm composed of a demand for better medical care after the war, the Flexner Report, which improved medical education and created a class of scientific physicians who needed a place to practice medicine, and the federal government's capacity for massive infrastructure projects, which were hugely successful during wartime. President Harry S. Truman, in a special message to Congress on November 19, 1945, declared that we should resolve now that the health of the nation is a national concern, that financial barriers in the way of attaining health shall be removed, and the health of all its citizens deserves the help of all the nation. This post-World War II political landscape led to the passage of the Hill-Burton Act in 1946 to improve healthcare in America. This act had a deceptively simple formula to fund healthcare, and it put American healthcare on a trajectory that continues to constrain our choices today. According to the Hill-Burton Act, the federal government matched $1 for every $2 raised by the state government. This favored communities that were able to issue bonds, leading to hospitals being built in growing suburbs away from people in need. This act targeted 4.5 beds per 1,000 people. This fixed ratio locked in fixed infrastructure costs, irrespective of demand, requiring hospitals to find ways to increase revenue. The Act's funding required hospitals to be non-profits. This tilted market dynamics, and for-profit hospitals found it hard to compete against these entrenched non-profit hospitals. Furthermore, these non-profit hospitals were required to provide free care. This had the unintended effect of cementing hospitals as the locus of uncompensated care instead of community clinics that could focus on keeping people out of the hospital. And lastly, the separate but equal loophole, which allowed hospitals to build separate hospitals or parallel wings in the hospital for colored people, locked in racial discrimination in healthcare for decades to come. By 1975, the Hill-Burton money accounted for approximately 17% of all post-war bed growth, adding approximately 70,000 beds and dramatically narrowing the rural-urban gap. And if you count the short-stay hospital beds, Hill-Burton money accounted for approximately 40% of all new hospital bed construction. And construction of all these hospital beds set the stage for the rise of insurance companies. In 1929, at Baylor University in Dallas, Texas, an official named Justin Ford Kimball developed a plan for school teachers. For a prepaid fee of 50 cents a month, the plan would guarantee teachers up to 21 days of care at a Baylor University hospital. So instead of patients paying for hospital services after they got sick often with money that they didn't have, this prepayment plan or the insurance system allowed people to pay a small fixed amount in advance. The plan's direct partnership with the hospital allowed the hospital to cover the cost of room and board, especially for the extra bed capacity that they now had due to the Hill-Burton Act. This prepayment arrangement and hospital partnership became the blueprint for the insurance companies, which is now called Blue Cross. This playbook took off, and over the next few decades, insurance plans started becoming popular. During World War II, the US government implemented a wage freeze to control inflation and stabilize the wartime economy. Employers who were struggling to attract labor used these health insurance plans as fringe benefits to attract people to work for them. Over time, these fringe benefits became a standard, and most employers adopted this practice. Congress, in its infinite wisdom, thought that employers were helping people, so they directed IRS to cement this practice into the economy by excluding employer premium payments from taxable income. As working class people were covered by insurance, political pressure gradually built up to extend coverage to the elderly who had retired from the workforce and low-income population who could not afford jobs that provided insurance benefits. This political pressure led to the birth of Medicare and Medicaid in 1965. This path dependency is demonstrated in the flowchart on the slide and can also be found in the written version of the article on PCPLens.com. The Hill-Burton Act accelerated the market for health insurance by focusing exclusively on hospital construction, and it set off at least 3 self-reinforcing loops with increasing returns, which is demonstrated in the flowchart on the slide. Essentially, the Hill-Burton Act dramatic expansion of hospitals burdened them with fixed costs, such as medical staff, utilities, etc. Therefore, to remain solvent and profitable, hospitals now needed a steady stream of customers, that is, patients. Since most hospitals were built to Hill-Burton standards, along with the implementation of prepaid plans, the cost of care delivery became predictable. This allowed actuaries to price the cost of care better and to develop insurance products. To attract patients, many hospitals partnered with insurance companies, and as more and more people became insured, hospital bed utilization increased, leading to higher revenue. This was the first reinforcing loop. As hospital revenues increased, they started building more capacity. More capacity meant higher fixed cost and increased pressure to remain profitable. This then meant providing more care to people irrespective of their needs to meet the revenue goals. As profits continued to increase, hospitals became larger and larger, dominating their communities. This was the second reinforcing loop. Non-profit hospitals using Hill-Burton money cemented their roles in the community by being one of the largest employers and generating goodwill by providing free care, which, by the way, they were required to do due to the Hill-Burton Act provisions. This allowed them to lobby legislators, leading to regulatory capture and a pro-hospital and insurance environment, cementing their role even further and preventing any competition. This was the third reinforcing loop. The foundational mistake in the Hill-Burton policy design was tying funds too rigidly to one type of solution, that is hospital beds. This made the system blind to a more efficient distribution of healthcare resources. This path dependency and funding from the Hill-Burton Act essentially locked out community health centers, outpatient clinics, and public health as viable options to provide meaningful healthcare to the population. The Hill-Burton Act essentially had 3 major lock-in effects. The first was institutional lock-in, where non-profit hospitals became political and economic powerhouses. This gave hospital administrators significant power and control over local politicians, leading to regulatory capture. The second was financial lock-in. Since the hospitals had to raise money from local bond markets to get matching Hill-Burton federal funds, they had a debt. And this debt, along with the operating costs for all the beds that were constructed, required significant recurring revenue. And for a long time, this financial lock-in made hospitals natural allies of the insurance companies, and they advocated for payment systems that guaranteed hospitals these recurring revenues. And lastly, physicians trained in Hill-Burton teaching hospitals learned to practice medicine in resource-intensive institutional settings, setting the stage for the healthcare system to focus more on acute care than preventive care. And the legacy of the Hill-Burton Act is far-reaching. Today, most PCPs don't go to hospitals to see their patients who are admitted, which is another story of our dysfunctional payment system. Now, hospital-based physicians called hospitalists manage them, and I used to be one in the past. However, due to the legacy of this hospital-centric training model, we are still required to be credentialed and on staff with a local hospital. So in day-to-day practice, this means that I have to remain subservient to a local hospital even though I don't see any patients there. Now, getting back to our story. Given that the federal dollars were tied to building hospital beds, it had 3 unintended consequences. The first, states built or over-allocated hospital beds where they were not needed, such as in sparsely populated areas. Outpatient facilities could have better served these places, but there was no economic incentive to build out these patient community clinics. The second was that states built hospital beds where they were able to raise money, that is, where they were able to issue bonds. In practice, this meant that hospital beds increased in areas where middle to high-income people lived, even if those areas were sparsely populated. And lastly, since most local funding went to construction for hospitals, it crowded out funding for outpatient facilities, community health centers, and public health programs. By 1973, less than 4% of the Hill-Burton grants had reached public health centers, far below the Act's original intent. The Government of Accountability Office 1974 audit report found that state agencies did not focus on construction or modernizing outpatient facilities, particularly where low-income people lived, and shifted a substantial amount of money to building hospital systems. The Hill-Burton Act is another significant historical reason for the paradoxical nature of the American healthcare system. We are home to some of the most technologically advanced medical care in the world, excelling at treating acute, complex diseases. And yet, we perform poorly in keeping people healthy. You can find a written version with references to the material and an audio podcast version on PCPLens.com. If you like this video, please sign up on PCPLens.com so that you don't miss the next episode when it's published. Thank you for watching this video. Take care and goodbye.